Let's begin our journey into the world of pharmacology. Softly, gently. There's no need to rush. You may be lying down, eyes closing, or simply listening with quiet curiosity in the background of your evening. However, you're here, you're welcome, and you're exactly where you need to be. Pharmacology is the study of drugs. But more precisely, it is the science of how drugs interact with living systems, how they behave inside the body, how they act upon cells, tissues, and organs, and how the body, in turn, responds to them. A drug, in this context, refers to any substance that is used to prevent, diagnose, treat, or relieve symptoms of disease. Not all chemicals are drugs. A drug must produce a specific biological effect when introduced into the body, and that effect must be measurable, purposeful, and reproducible. Some substances, like food, nutrients, or toxins, may affect the body, but unless they're used with medical intent, they're not considered pharmacological agents. Pharmacology is a large and structured field. To understand it more clearly, it helps to divide it into two broad areas, pharmacokinetics and pharmacodynamics. These two areas describe different sides of the same interaction. One looks at what the body does to the drug. The other looks at what the drug does to the body. Let's softly begin with pharmacokinetics. Pharmacokinetics is the study of how a drug moves through the body. This includes how it is absorbed, how it is distributed to different tissues, how it is metabolized or chemically altered, and finally, how it is excreted. We will explore these steps more deeply later on, but for now, it's enough to think of pharmacokinetics as describing the journey a drug takes from entry through transformation to exit. Now let's shift to pharmacodynamics. This is the study of what the drug does once it arrives at its target. It looks at how a drug produces its effects, how it binds to receptors, how it triggers or blocks signals, and how those actions lead to changes in cells or systems. Pharmacodynamics helps us understand a drug's mechanism of action, its strength, its duration, and its relationship to the body's existing biological processes. Together, pharmacokinetics and pharmacodynamics provide a full picture. They help us understand how a drug reaches its target and what it does when it gets there. You may also hear the term receptor used often in pharmacology. A receptor is a specific protein in or on a cell that a drug or natural molecule can bind to. Think of it as a biological lock and the drug as a key. When the key fits, the receptor responds, sometimes by triggering a cellular reaction, sometimes by blocking one. But don't worry about memorizing the terms. Let them pass through your awareness gently. They will return later in more detail. For now, just notice the ideas and how they connect. Another helpful concept to introduce early is the idea of a dose-response relationship. This refers to how the effects of a drug change as the dose increases. In most cases, a small dose may cause a small effect, and a larger dose, a larger one, until the effect plateaus or becomes harmful. Understanding this relationship helps determine how much of a drug to give and how often. It is the foundation for safe, effective dosing. Now, in modern medicine, drugs are classified into different categories or classes. These classes are based on the drug's action, its chemical structure, or its use. For example, drugs that reduce blood pressure may be grouped together, even if their individual mechanisms differ. These classifications help healthcare providers choose the right medication based on the condition being treated, the expected effect, and the patient's needs. All of these topics, pharmacokinetics, pharmacodynamics, receptors, dosage, and classification, are foundations of pharmacology. They give us the language and logic to understand how drugs are studied, how they are prescribed, and how they work within us. As we move forward, each of these ideas will be explored more deeply, one gentle layer at a time. For now, there is no need to hold on tightly to any specific definition or detail. Just allow the structure to form in your mind, quietly and calmly. Pharmacology may seem complex, but beneath its surface, it is a study of patterns, of signals, and responses, of balance and interaction, and of how small molecules can guide the body toward healing. So, as we bring this introductory chapter to a close, you might feel a bit more familiar with the path ahead. You've now heard the basic shape of the subject, its scope, its branches, its early vocabulary, and most importantly, you've begun the process gently, without pressure. Let's carry this calm energy forward as we prepare to explore how drugs move through the body in the next section, Pharmacokinetics. Take a breath, let it settle, and when you're ready, we'll continue. Let us now continue our quiet journey deeper into the study of pharmacology. In this chapter, we begin to explore pharmacokinetics, a term that describes how the body interacts with a drug over time and through space. It answers the question, what does the body do to the drug? From the moment it enters until the moment it leaves. You do not need to hold on tightly to any part of this. Let the ideas pass softly through your mind. Let them settle where they will. Pharmacokinetics is often described using 4 main processes. They are absorption, distribution, metabolism, and excretion. You may hear these 4 steps referred to by the abbreviation ADME. Each step helps explain the path a drug takes through the body, how it enters, where it travels, how it is changed, and how it is removed. Let's begin gently with absorption. Absorption refers to how a drug moves from its site of administration into the bloodstream. If a drug is taken by mouth, for example, it must first pass through the digestive system before reaching the circulation. This journey involves crossing biological membranes, and this process can vary depending on the drug's chemical properties, the form it's given in, and the body's own physiology. Some drugs are absorbed quickly, others more slowly. Some are absorbed completely, others only in part. This leads us to a helpful term, bioavailability. Bioavailability describes the fraction of a drug that reaches the bloodstream in its active form. When a drug is given intravenously, directly into the veins, its bioavailability is considered to be 100%, but when taken by mouth, much of it may be lost or altered before it reaches circulation. Understanding bioavailability helps us know how much of a drug actually reaches the body's tissues, ready to do its work. Now that we've softly introduced absorption, let's move to the second phase, distribution. Once a drug is absorbed into the bloodstream, it begins to circulate and is carried to various tissues and organs. This process, distribution, determines where the drug goes, how quickly it reaches its target, and how long it stays there. Not all drugs distribute evenly. Some may concentrate in fatty tissues. Others may bind tightly to proteins in the blood. Some may have difficulty crossing certain barriers, like the blood-brain barrier, which protects the brain from many substances. The pattern of distribution affects how a drug works, how strong its effects are, and how long those effects last. Let's now move gently into the third stage, metabolism. Metabolism refers to how the body chemically modifies a drug. This usually happens in the liver, which contains enzymes that transform drugs into more water-soluble forms, making them easier to eliminate. The liver does not always inactivate a drug. Sometimes, metabolism can activate a substance, converting it into its usable form. These are called prodrugs. A useful concept to introduce here is first-pass metabolism. This occurs when a drug taken by mouth is significantly metabolized by the liver before it enters the bloodstream. As a result, only a small portion of the original dose may reach the rest of the body. This effect influences how much of a drug is needed, and whether an alternative route, like injection or sublingual delivery, may be more effective. Another helpful term here is half-life. A drug's half-life is the amount of time it takes for its concentration in the blood to reduce by half. This concept is important for understanding how long a drug remains active in the body and how frequently it needs to be taken. Some drugs have short half-lives and need to be given often. Others remain in the body longer and can be given less frequently. Let's now move to the final phase of pharmacokinetics, excretion. Excretion refers to how the drug or its metabolites are removed from the body. The main organ responsible for this is the kidney, which filters the blood and produces urine. Other routes of excretion include the lungs, bile, sweat, and even breast milk. Some drugs leave the body quickly, others linger, stored in fat or slowly cleared by the liver. The rate of excretion determines how long the effects of a drug lasts and helps healthcare providers decide how often a drug should be administered. So now we've softly moved through the 4 stages of pharmacokinetics: absorption, how a drug enters the body; distribution, where it travels; metabolism, how it is changed; and excretion, how it leaves. These processes are continuous and overlapping, not rigid steps, but flowing phases in a dynamic system. Together, they help determine a drug's onset, intensity, and duration of action. As you let these ideas settle, remember that you are not expected to master them all at once. They will reappear gently in later chapters, each time adding a little more depth and clarity. The movement of a drug through the body, from entry to action to exit, is part of what makes pharmacology both a science and an art. It reflects the body's complexity and the careful consideration that goes into designing medications that are safe, effective, and precise. Before we close, let's softly revisit a few guiding terms. Pharmacokinetics, the study of how the body processes a drug. Bioavailability, the portion of drug that reaches the bloodstream in active form. First-pass metabolism, the liver's early processing that may reduce drug availability. Half-life, the time it takes for half the drug to be cleared from the blood. And finally, the ADME framework: absorption, distribution, metabolism, and excretion, the 4 stages that gently shape a drug's life within the body. Let these concepts float. No need to grasp them tightly. They will become clearer with time and return to you in future chapters when you're ready. As we leave this section behind, feel free to rest your mind. Let your breath be steady and your thoughts soft. In the next part of our journey, we'll begin to explore what drugs do to the body, a gentle shift into pharmacodynamics. Until then, simply rest and let the learning continue quietly and calmly. Now that we've gently explored how the body affects a drug through the lens of pharmacokinetics, let us slowly shift our attention to the other side of the interaction, what the drug does to the body. This field is called pharmacodynamics. Pharmacodynamics helps us understand how a drug produces its intended effect, how it binds, how it signals, and how it ultimately influences cells, tissues, and systems. You might imagine this as a quiet, molecular conversation, a subtle exchange between the drug and the structures it touches. The key concept at the center of pharmacodynamics is the receptor. A receptor is a protein often found on the surface of a cell or within it that responds to specific chemical messengers. These messengers might be naturally occurring, like hormones or neurotransmitters, or they might be introduced in the form of medications. When a drug reaches its target, it may bind to a receptor, fitting into it much like a key fits a lock. This binding may trigger a response, or prevent one. If the drug activates the receptor, causing it to produce a biological effect, we call it an agonist. If the drug binds but blocks the receptor, preventing the usual effect, it is known as an antagonist. Some drugs act partially, producing a weaker signal. These are called partial agonists. Others may bind in a way that modifies the receptor's behavior over time. These include inverse agonists and modulators. You don't need to remember each name. Just let the overall pattern begin to settle quietly in your mind. Drugs can mimic, block, or modulate the body's own chemical signals. This is the heart of pharmacodynamics. Now that we've introduced receptors and drug actions, let's ease into the concept of the dose-response relationship. This describes how a drug's effect changes as the dose increases. At lower doses, the response may be small. As the dose rises, the effect increases until it reaches a point where no further benefit is seen. This leveling off is called the maximum effect, or Emax. Visualizing this, we get what is called a dose-response curve, a gentle slope that shows how much drug is needed to produce how much effect. This curve helps researchers and clinicians understand the strength and behavior of a drug. From this curve, two important ideas emerge. The first is potency. Potency describes how much of a drug is needed to produce a certain level of effect. A highly potent drug requires only a small dose to reach its desired action. A less potent drug may need a higher dose to do the same. The second is efficacy. Efficacy refers to the maximum effect a drug can produce, regardless of how much is given. Some drugs have high efficacy. They produce a strong, full effect. Others may have lower efficacy. Even at high doses, they create only a partial response. Potency and efficacy are not the same. A drug may be highly potent, yet have low efficacy, or it may require a larger dose, but be capable of producing a powerful result. These ideas help guide clinical decisions, choosing the right drug, at the right dose, for the right effect. Another gentle concept to introduce here is the therapeutic index. The therapeutic index is a comparison between a drug's beneficial dose and its potentially harmful dose. More specifically, it's the ratio between the dose that produces a therapeutic effect and the dose that could cause toxicity. A wide therapeutic index means the drug is relatively safe. There is a comfortable margin between effectiveness and danger. A narrow therapeutic index means the drug must be dosed with care. Small changes in dose may lead to unwanted effects. Understanding a drug's therapeutic index helps clinicians balance benefit and risk and guides how closely a patient needs to be monitored. So now, softly resting in your awareness are the key ideas of pharmacodynamics, how drugs bind to receptors, whether they activate or block those receptors, and how the dose of a drug relates to the strength and safety of its effects. Let's gently recap what we've covered so far. Pharmacodynamics describes the interaction between drugs and the body. Drugs may act as agonists, antagonists, or somewhere in between. They influence receptors, structures that respond to chemical signals. The dose-response relationship explains how effects change with dose, while potency and efficacy help describe a drug's power and capability. And the therapeutic index helps us understand the balance between helpfulness and harm. These principles form the backbone of how drugs are used in medicine. They guide how treatments are chosen and how safety is maintained over time. You don't need to memorize or analyze. Just let the shape of these concepts form gently in your mind. Let them float softly, like leaves in a quiet stream. As we close this section, allow your breath to slow. Let the stillness of this learning take root without pressure or urgency. In the next chapter, we'll begin to trace the path of a drug before it ever reaches the body, exploring how new medicines are discovered, tested, and approved for use. Until then, rest, listen, and let the learning continue in calmness and care. As we continue our gentle journey through the world of pharmacology, let us now shift our focus to the path a drug takes before it ever reaches a patient's body. This process is called drug development and approval. It is a long, careful journey, one that begins with curiosity and ends, after years of testing, with the hope of healing. In this section, we'll calmly walk through each stage of that process, not as facts to memorize, but as a quiet timeline, unfolding with purpose and patience. The first step in this journey is discovery. Researchers begin by identifying a potential target, often a receptor, enzyme, or protein involved in a disease process. They then explore chemical compounds or biological molecules that might influence that target in a beneficial way. This stage involves screening many compounds, testing how they behave in controlled environments, and narrowing down the ones that show the most promise. Once a promising compound is found, we enter what is called the preclinical stage. Here, the compound is tested extensively outside the human body. This includes in vitro studies, which take place in lab dishes or test tubes, and in vivo studies, often using animal models. These tests help researchers understand the drug's pharmacokinetics and pharmacodynamics, how the drug moves through a body, and how it interacts with cells and tissues. Safety is especially important in this stage. Scientists observe how the drug behaves, how it is absorbed, where it travels, how it is metabolized, and how it is excreted. If the drug appears safe and potentially effective, researchers can then request permission to begin testing in humans. This leads us to the clinical trial phases. These trials are conducted in 4 main phases, each one building on the results of the previous. Phase 1 is the beginning of human testing. This phase usually involves a small group of healthy volunteers. The goal is to evaluate basic safety, understand how the drug is processed in the human body, and identify any early side effects. Phase 2 expands testing to a slightly larger group, usually individuals, who have the condition the drug is meant to treat. Here, researchers begin to study whether the drug is effective, while continuing to monitor safety and dosage. Phase 3 trials involve a much larger group of participants. This phase compares the new drug to existing treatments or placebos. Researchers look for evidence of clear benefit while carefully tracking any adverse effects. If Phase 3 is successful, the company can apply for approval from regulatory authorities. In most countries, this means submitting the data to organizations like the FDA in the United States or the IMA in Europe. Regulatory bodies carefully review all available information, the drug's development, testing, safety data, and effectiveness. This review process can take months or even years. If the benefits are judged to outweigh the risks, the drug is granted approval for use in the general population. Even after approval, the process is not over. This is where Phase 4 begins, often called post-marketing surveillance. In Phase 4, the drug is monitored while being used in real-world settings. This helps identify rare or long-term side effects that may not have appeared during earlier trials. Throughout this entire journey, there is one principle that remains central: ethics. Drug development must follow strict ethical guidelines, designed to protect the dignity and rights of every participant. This includes informed consent, a process in which individuals are fully educated about the risks and benefits of participating in a trial, and must agree freely without pressure. Ethics committees and regulatory boards review every stage of the research to ensure fairness, transparency, and safety. When done correctly, this process is not rushed. It takes time and care and respect for the people who participate. Along the way, let's gently pause here and softly review the path we've taken. Drug development begins with discovery, the careful search for a compound that can help. It then moves to preclinical testing, where safety and biological activity are explored outside the human body. With enough promise, the drug enters clinical trials, starting with Phase 1 in healthy volunteers, then Phase 2 with patients, followed by larger Phase 3 studies to confirm benefit. After careful regulatory review, the drug may be approved. And in Phase 4, monitoring continues long after it reaches the public. Each step is part of a quiet, thoughtful process, driven by science, guided by ethics, and always focused on the well-being of future patients. There is no need to remember each phase by name. Just let the soft shape of the process rest in your mind. Discovery, testing, approval, ongoing care. In the next section, we will begin to explore how individual differences like age, genetics, or organ function can influence how drugs behave in different people. But for now, allow your mind to rest in this gentle rhythm of understanding. Let the learning settle softly and slowly, as we continue together on this calm and curious path. Now that we've gently explored how drugs move through the body and how they create effects once they arrive, let us move a little closer to the quiet spaces where these effects begin at the molecular level. This section is a calm look at the specific places where drugs act. We call these targets. Drug targets are the structures within the body that drugs are designed to bind to or influence. Understanding these targets helps us understand why certain drugs work and how their actions are so carefully tailored. The most common class of targets is called receptors. Receptors are proteins, often located on the surface of cells, though some rest inside the cell as well. Their job is to receive signals, chemical messengers that carry instructions. These messengers might be hormones, neurotransmitters, or, in the case of medications, synthetic molecules. When a messenger binds to its receptor, it creates a change. Something inside the cell shifts. A process is turned on or turned off. This is known as signal transduction, a quiet chain reaction within the cell. The drug, acting as a ligand, fits into the receptor like a soft key turning gently in a lock. This interaction is called ligand-receptor binding. Some drugs are agonists. They mimic natural ligands and activate the receptor, triggering a response similar to what the body would create on its own. Other drugs are antagonists. They bind to the receptor but do not activate it. Instead, they block the site, preventing natural signals from arriving. Both types are useful. Agonists can restore function when something is missing. Antagonists can reduce or block activity when there is too much. Inside the cell, work with second messengers. These are small molecules that carry the signal inward from the surface of the cell to deeper structures. Common second messengers include camp and calcium ions. These molecules help spread the message, amplifying the effect gently within the cell. Now, let's softly shift our attention to another type of target, enzymes. Enzymes are biological catalysts. They speed up chemical reactions in the body without being consumed by those reactions. Sometimes a drug needs to inhibit an enzyme, meaning it slows down or stops the enzyme's activity. This is called asterisk enzyme inhibition. There are different kinds, but all involve the drug interacting with the enzyme to reduce its ability to function. One important example is a class of drugs that inhibits the enzyme, a CE angiotensin-converting enzyme used to treat high blood pressure. By gently preventing this enzyme's activity, the drug lowers blood pressure over time. In some cases, drugs may enhance enzyme activity, though this is less common. These are known as enzyme activators, beyond receptors. And enzymes. There are other subtle but important targets. One is the ion channel. Ion channels are pore-like structures in the membranes of cells. They allow charged particles, like sodium, potassium, or calcium, to flow in or out. This flow helps generate electrical signals, especially in nerve and muscle cells. Certain drugs can block or open these channels. For example, some anti-seizure medications work by calming the activity of ion channels in neurons, reducing the chance of sudden, uncontrolled electrical activity. Another important class of targets includes carrier proteins. These proteins transport substances across cell membranes. They are especially important in the brain and kidneys. Antidepressants, like SSRIs, selective serotonin reuptake inhibitors, target carrier proteins that normally remove serotonin from the space between nerve cells. By blocking this process, these drugs increase serotonin levels in a controlled, steady way. Let's pause briefly here and take a gentle breath. So far, we've seen that drugs can act on several types of targets. Asterisk receptors, where they may act as agonists or antagonists. Enzymes, which they may inhibit or occasionally activate. Ion channels, which help regulate electrical activity. Asterisk and carrier proteins, which manage the movement of substances. All of these interactions are guided by chemistry, by the shape, charge, and fit of the molecules involved. But they are also guided by intention, by the careful design of drugs to match specific processes in the body. It's important to remember that these targets are not isolated. They often work together in quiet coordination to carry out the body's most essential functions. Even a small interaction, a single receptor being activated or blocked, can ripple out through a cell, and from there, affect tissues, systems, and health. You don't need to memorize each target or pathway. Simply let the gentle framework settle in your mind. Drugs find their way to precise places. They fit into receptors, influence enzymes, shape ion flow, or guide protein transport. And through these interactions, they bring change. Some changes are meant to relieve pain. Some reduce inflammation. Some support mental balance. Others regulate heart rhythms or immune responses. But all begin with a simple molecular connection, a quiet touch at the level of cells. As we drift toward the end of this section, let's gently reinforce the key idea. Drugs are designed to act on targets. These targets include receptors, enzymes, ion channels, and transport proteins. Each type plays a role in cellular communication and function, and when drugs interact with these targets, they either mimic, block, slow down, or assist natural processes. Understanding these interactions, even softly and without strain, builds the foundation for deeper insight into pharmacology. In the next section, we will explore how the body's own differences, its age, genetics, and organ function can influence how these drug-target interactions unfold. But for now, allow this quiet understanding to rest gently in your thoughts. No pressure to recall or analyze. Just let the patterns take shape softly and slowly as your learning continues at its own peaceful pace. As we continue along our gentle path through pharmacology, let's now pause to explore something essential. How much of a drug is needed, and how we decide what is safe and what is not. Drug dosage refers to the amount of a drug given to achieve a desired effect. It's a quiet science of balance, not too much and not too little. Every individual responds slightly differently to medications. Body weight, age, genetics, organ function, and even stress levels can influence how a person absorbs and responds to a drug. That's why determining the right dose is so important. It must be enough to produce a therapeutic effect, but not so much that it causes harm. Let's take a slow breath here and begin gently with the idea of the dose-response relationship. This concept describes how a drug's effect changes as its dose increases. At lower doses, there may be little to no effect. As the dose rises, the effect becomes more noticeable. Eventually, a plateau is reached, where increasing the dose further no longer adds much benefit and may begin to introduce risk. To better understand this curve, scientists use specific reference points. One is called the or the effective dose for 50% of the population. This is the dose at which half of a group shows the intended therapeutic effect. It's a standard point used to compare drug potency and helps guide dosing in early research. Another important value is the LD, the lethal dose for 50% of the population. This measure comes from animal studies and represents the amount of a substance that would be fatal to half the test subjects. While it is not used directly in human medicine, it provides a boundary, a marker of potential harm. Between the ED and the LD, we find something called the therapeutic index. This is a ratio. It compares the effective dose to the toxic or lethal dose. The wider the gap between these two, the safer the drug is considered to be. A drug with a wide therapeutic index can tolerate some variation in dosing. This allows for flexibility in patient response. But some drugs have a narrow therapeutic index. This means the helpful dose is close to the harmful or toxic dose. For these drugs, precision becomes even more important. Examples include certain heart medications, blood thinners, and drugs used for epilepsy. When using such medications, clinicians often monitor blood levels carefully, adjusting the dose as needed to stay within the therapeutic window. The therapeutic window is the space between the minimum effective concentration and the minimum toxic concentration. Staying within this window helps ensure the drug works as intended without producing harm. Let's take a moment to revisit these ideas gently. Asterisk EDAS is the dose that works for half the population. LD is the dose that would be lethal to half. The therapeutic index compares these two, showing us how safely a drug can be used. And the therapeutic window is the safe, comfortable range for treatment. With this understanding, we can now softly explore how clinicians choose a dose for a patient. The process begins with guidelines developed through clinical trials, but from there, the dose is adjusted based on the individual. Factors that influence dosing include body weight, age, kidney and liver function, other medications, and the person's overall health. For example, older adults may process drugs more slowly, requiring smaller or less frequent doses. Children, with their developing systems, also need special adjustments. People with impaired liver or kidney function may not clear drugs from their system as quickly. This can lead to accumulation over time and possible toxicity. That is why, in clinical settings, doctors often start low and go slow, beginning with a lower dose and gradually increasing it while observing the patient's response. In some cases, drug levels are measured directly in the blood, especially when using medications with a narrow therapeutic range. This helps ensure the drug remains within its safe window. Not too much, not too little, just enough to support healing. Let's now pause and softly reflect on what we've covered. Drug dosage is not a fixed value. It's a careful estimate adjusted for the unique needs of each person. The dose-response relationship helps us understand how effects change as doses increase. The ED gives us a reference for effectiveness. The LD reminds us of the risk, The therapeutic index shows us how wide that margin is, and the therapeutic window is the gentle space in which healing can occur, safely and effectively. All of this speaks to the precision of pharmacology. A medicine's value lies not only in its chemistry, but in how carefully it's used. As we reach the end of this section, you might feel a quiet sense of clarity. No need to memorize. Just allow the ideas to settle. In pharmacology, dosing is about more than numbers. It's about listening to the body's response, watching closely, and adjusting gently. In the next section, we'll explore how a person's age, genetics, and health status can affect how drugs behave inside the body. But for now, let this knowledge rest with you calmly as you drift deeper into your learning and deeper into stillness. As our journey continues, let's now begin to gently explore how pharmacology meets the nervous system. The nervous system is the body's communication network. It sends messages, receives signals, and maintains delicate balance. Medications that act on the nervous system can influence thoughts, mood, sensation, and even sleep. Some quiet the mind, some awaken it, and others gently adjust what lies in between. There are two main parts of the nervous system that we'll focus on now: the central nervous system and the autonomic nervous system. Let's begin slowly with the central nervous system, often shortened to CNS. The CNS includes the brain and spinal cord. It is the control center, processing incoming information, coordinating movement, and guiding emotion and awareness. Drugs that act on the CNS can have a wide range of effects. They might cause sedation or alertness. They may ease pain or help balance mood. Let's gently introduce a few common drug types that influence the central nervous system. First, we have sedatives and hypnotics. These are drugs that calm the nervous system. They help reduce anxiety, promote sleep, and sometimes prepare patients for medical procedures. Benzodiazepines, such as diazepam and lorazepam, are examples of sedatives. They work by enhancing the effect of a neurotransmitter called GABA gamma-aminobutyric acid. GABA is the brain's primary inhibitory chemical messenger. It reduces nerve activity, bringing about a sense of calm and relaxation. When GABA levels rise, the nervous system slows, muscles relax, thoughts quiet, and sleep becomes easier to reach. Now, let's softly turn to antidepressants. These medications help regulate mood, especially in people experiencing depression, anxiety, or certain mood disorders. One widely used class of antidepressants is SSRIs, or selective serotonin reuptake inhibitors. Examples include fluoxetine and these drugs work by increasing levels of serotonin, a neurotransmitter that influences mood, appetite, and emotional balance. By preventing serotonin from being reabsorbed too quickly, SSRIs allow it to remain active in the brain for longer. This gentle increase helps restore mood over time. Another important class of CNS drugs is the antipsychotics. These are used in conditions like schizophrenia and certain forms of bipolar disorder. They often act by altering levels of dopamine, a neurotransmitter linked to motivation, movement, and the brain's reward system. In some psychiatric conditions, dopamine signaling becomes overactive. Antipsychotics help reduce this activity, bringing thought patterns back into balance. Let's now pause and softly revisit the neurotransmitters we've mentioned. GABA, calming, inhibitory, sleep-promoting, serotonin, mood-stabilizing, gentle, emotional, dopamine involved in reward, motivation, and movement. Each of these tiny messengers can be influenced by medications. Each one plays a subtle part in the brain's quiet symphony. Now that we've explored the central nervous system, let's move gently into the autonomic nervous system, the ANS. This system controls automatic body functions like heart rate, digestion, breathing, and blood pressure. It operates without conscious thought, quietly in the background. The autonomic nervous system has two main branches: the sympathetic nervous system and the parasympathetic nervous system. The sympathetic system prepares the body for action. It is often called the fight or flight system. It increases heart rate, opens airways, and redirects blood to muscles. In contrast, the parasympathetic system is responsible for rest and digest. It slows the heart rate, stimulates digestion, and helps the body relax and recover. Some drugs stimulate one part of this system, while others inhibit it. Let's gently look at a few important examples. Adrenergic drugs mimic or block the action of norepinephrine and epinephrine, the body's stress response messengers. When used therapeutically, these drugs can raise blood pressure, treat asthma, or help manage heart conditions. Some adrenergic agonists stimulate receptors that speed up the heart. Others may cause blood vessels to narrow, raising blood pressure. On the other hand, adrenergic blockers, also called beta blockers, are used to slow the heart, reduce anxiety, and help with hypertension. Another group of drugs targets acetylcholine, a neurotransmitter involved in muscle contraction, memory, and parasympathetic functions. Cholinergic drugs can enhance acetylcholine activity. They may be used in conditions like Alzheimer's disease to support memory and cognition. Anticholinergic drugs, by contrast, block the action of acetylcholine. They are used to reduce muscle spasms, slow gut movement, or dry secretions during surgery. Let's take another quiet moment to gently reflect. The CNS guides thought, feeling, and movement. The ANS manages automatic processes like heart rate and digestion. Drugs that act on the nervous system may influence one or both of these divisions. And now, as we begin to round out this section, let's softly visit a few final, commonly discussed drug classes that work on the nervous system. We've already mentioned SSR is selective serotonin reuptake inhibitors, used in the treatment of depression and anxiety. They gradually enhance serotonin activity, promoting emotional stability. We've also touched on benzodiazepines, sedatives that support sleep and calmness by enhancing GABA. Another important group is the opioids. These drugs, including morphine and oxycodone, are powerful pain relievers. They act on opioid receptors in the brain and spinal cord, reducing the perception of pain and producing a sense of comfort or euphoria. Opioids can be essential in managing acute or chronic pain, but they also carry risks, including dependence and overdose, especially at high doses or with prolonged use. For this reason, their use is carefully monitored. Clinicians aim to provide relief while minimizing harm, with care, with knowledge, and with close attention to the body's quiet responses. And so, as this section draws to a close, let's softly review where we've been. We explored how drugs interact with the nervous system, gently influencing mood, sensation, and movement. We learned about the CNS, with its calming neurotransmitters like GABA and serotonin, and about medications that help regulate mood and sleep. We touched on the ANS with its role in automatic body functions, and how drugs can either stimulate or suppress these pathways. And we ended with gentle consideration of common nervous system drug classes, including SSR, is benzodiazepines, and opioids. Each of these substances acts not with force, but with subtle influence. They work by modulating signals, adjusting rhythms, and helping the body return to balance. Let your mind hold these ideas gently, like soft impressions on sand. Need to memorize. Just rest with the awareness that the nervous system is both delicate and powerful, and that pharmacology respects its flow. In the next part of our journey, we'll begin to explore how drugs interact with the immune system and inflammation. But for now, breathe slowly and let the nervous system settle as you move deeper into calm and deeper into learning. Let us now shift our focus to the quiet rhythms of the heart and the gentle flow of blood through the body. The cardiovascular system is the body's circulating life force. It delivers oxygen and nutrients, removes waste, and helps maintain internal balance. In this section, we'll explore how pharmacology supports this system, protecting its rhythm, regulating its pressure, and guiding its vessels with care. We begin with a calm understanding of how the heart and blood vessels work together. The heart pumps, the vessels carry, and the blood flows in a continuous, steady cycle. When this balance is disturbed through high pressure, fluid overload, or irregular rhythms, medications may be used to restore harmony. Let's gently begin with a group of medications called antihypertensives. Antihypertensives help lower blood pressure. They are used when pressure in the arteries becomes too high, a condition known as hypertension. Sustained high blood pressure places strain on the heart, the vessels, and the kidneys. It increases the risk of heart disease, stroke, and organ damage. There are several types of antihypertensives, each working in a slightly different way. One important class is the ACE inhibitors. ACE stands for angiotensin converting enzyme. This enzyme plays a role in narrowing blood vessels. When blood vessels narrow, pressure increases. ACE inhibitors block this enzyme, allowing blood vessels to relax and widen. This lowers blood pressure and eases the heart's workload. Common examples include enalapril, lisinopril, and ramipril. Now let's softly turn to another class, the beta blockers. Beta blockers reduce the effects of adrenaline, a hormone that increases heart rate and blood pressure. By blocking beta receptors on the heart, these drugs help slow the heartbeat, reduce its force, and lower blood pressure. They are often used in heart failure, angina, and after heart attacks. Examples include metoprolol, atenolol, and propranolol. Next, we meet the calcium channel blockers. Calcium plays a role in muscle contraction, including the muscles in blood vessels and the heart. These medications block calcium from entering cells. This relaxes blood vessels, reduces resistance, and lowers pressure. Some calcium channel blockers also slow the heart rate. Examples include amlodipine and verapamil. Together, these three groups, ACE inhibitors, beta blockers, and calcium channel blockers, form the gentle foundation of many hypertension treatments. Let's now introduce another group, the diuretics. Diuretics help the body remove excess fluid through increased urination. By lowering blood volume, they reduce pressure within the vessels and lighten the heart's workload. They are often used to treat heart failure, edema, or fluid retention, and sometimes hypertension. A common type is the thiazide diuretic, such as hydrochlorothiazide. Others include loop diuretics, like furosemide, which are stronger and used in more urgent fluid overload. Now that we understand medications that lower pressure and reduce fluid, let's softly move to those that influence rhythm. The heartbeat follows an electrical pattern, a wave of signals that triggers each contraction. When this rhythm becomes irregular, it is known as an arrhythmia. Drugs, called antiarrhythmics, are used to stabilize the heart's rhythm. They do this by affecting the movement of ions, like sodium, potassium, and calcium, through heart cells. Some slow the heart rate, some make it more regular. Examples include amiodarone, lidocaine, and sotalol. These medications are carefully selected based on the type of arrhythmia and the patient's overall condition. Now let's gently explore a group of drugs called vasodilators. Vasodilators relax and widen blood vessels. This reduces resistance, lowers pressure, and improves blood flow. One well-known vasodilator is nitroglycerin. It is often used to treat angina, a type of chest pain that occurs when the heart muscle doesn't get enough oxygen. Nitroglycerin opens up the vessels, especially those supplying the heart. This eases the pain and reduces the heart's demand for oxygen. Other vasodilators may be used in emergencies to quickly reduce dangerously high blood pressure. Each of these medications, from ACE inhibitors to nitrates, works to guide the cardiovascular system back to balance. They do not force the body, they assist it, quietly adjusting pressure, volume, and rhythm. Let's take a gentle moment to reflect. Antihypertensives lower blood pressure through different mechanisms. ACE inhibitors relax vessels. Beta blockers slow the heart. Calcium channel blockers ease contractions. Diuretics remove excess fluid. Antiarrhythmics restore rhythm. Vasodilators widen vessels to allow smooth, steady flow. These drug classes are often used together in low doses to achieve gentle control with minimal side effects. Now imagine the blood flowing softly through open vessels, the heart beating at a calm, steady pace, pressure held in quiet balance, chemistry working in harmony with biology. In conditions like heart failure, medications are chosen carefully to reduce strain on the heart, remove excess fluid, and support proper rhythm. In angina, they reduce oxygen demand and improve blood flow to heart tissues. And in hypertension, they help prevent long-term damage to organs and vessels. Pharmacology here becomes a form of guidance, a steady hand, helping the heart carry on with its lifelong work. As we reach the close of this section, let the rhythm of the cardiovascular system remain with you like a soft pulse. Remember, each drug discussed supports the flow of life, the steady, silent circulation that keeps every cell nourished and every tissue alive. Let the knowledge settle gently. There is no rush to remember, only the calm awareness that these medicines exist to help restore balance. In the next part of our journey, we'll begin to explore how drugs interact with the immune system and how they help manage inflammation and infection. But for now, feel the quiet rhythm and let yourself drift deeper into rest and into learning. Now, let us gently shift our attention to two systems that work quietly, moment by moment, to support life and comfort. The respiratory system draws in oxygen and releases carbon dioxide. It allows each breath to nourish the body. The gastrointestinal system, or digestive tract, absorbs nutrients and processes the food we eat into energy and waste. In this soft chapter, we'll explore how pharmacology supports these systems, soothing the lungs and easing the digestive pathway. Let's begin with the respiratory system. When the airways become narrow or inflamed, it becomes harder to breathe. Conditions like asthma and chronic obstructive pulmonary disease, also called COPD, can cause coughing, wheezing, and shortness of breath. To relieve these symptoms, certain medications are used gently, opening the airways, reducing inflammation, and thinning mucus. One important group is called bronchodilators. Help relax the muscles around the airways, allowing them to widen. This makes it easier to breathe. There are two main types, short-acting and long-acting. Short-acting bronchodilators, like salbutamol, work quickly and are often used during sudden symptoms. Long-acting ones, such as salmeterol, are used regularly to prevent symptoms throughout the day and night. Next, we have the corticosteroids. These are not the same as muscle-building steroids. Corticosteroids reduce inflammation in the lungs. They help calm the immune system's response, which can otherwise narrow the airways. In asthma and COPD, inhaled corticosteroids, such as budesonide or fluticasone, are often used to prevent flare-ups. Now let's introduce a gentler category, the mucolytics. Mucolytics help thin and loosen mucus in the airways, making it easier to cough up and clear. One common mucolytic is acetylcysteine. It's used in chronic conditions where thick mucus builds up in the lungs. To softly recap, bronchodilators open the airways. Corticosteroids reduce inflammation. Mucolytics help clear the mucus. Each plays a unique role in supporting the act of breathing with greater ease. Now, let us slowly move down to the gastrointestinal system. Here, pharmacology helps manage conditions such as acid reflux, peptic ulcers, and indigestion. Let's begin with acid reflux, a condition where stomach acid flows back into the esophagus, causing a burning sensation known as heartburn. To relieve this, we use medications that reduce or neutralize stomach acid. One group is called antacids. Antacids work quickly by neutralizing existing stomach acid. They bring short-term relief. Examples include calcium carbonate and magnesium hydroxide. For longer-lasting control, we turn to H2 blockers. These drugs reduce acid production by blocking histamine receptors in the stomach lining. Histamine is a natural chemical that signals the stomach to make acid. Common H2 blockers include ranitidine. Even more effective and often used in chronic cases are proton pump inhibitors, or PP. These medications block the final step in acid production within the stomach. They are very effective for healing ulcers and preventing reflux. Examples include omeprazole, pantoprazole, and lansoprazole. Now, let's gently talk about peptic ulcers. Peptic ulcers are sores that form in the lining of the stomach or small intestine. They may be caused by excess acid, a bacterium called Helicobacter pylori, or the use of certain medications like NSAIDs. Treatment often includes PP to reduce acid and antibiotics to clear the infection if needed. In milder digestive discomfort, antacids or H2 blockers may provide soothing relief. Some medications, like prokinetics, help move food more smoothly through the digestive tract. This can help prevent bloating, nausea, and slow digestion. As we near the end of this section, let's take a quiet moment to summarize. In the lungs, we use bronchodilators to open airways, corticosteroids to reduce inflammation, mucolytics to thin mucus, and in the digestive system, we use antacids to neutralize acid, H to blockers to reduce acid production, proton pump inhibitors to stop acid at its source, prokinetics to support smooth movement. Each medication plays its part, calming discomfort, protecting tissue, and supporting natural processes. Now, as you breathe in and gently breathe out, picture the lungs expanding with ease and the stomach resting in comfort. The body supported, not pushed, but guided. With understanding, even complex systems feel familiar. Let this knowledge settle like soft breath, slowly and calmly. In the next chapter, we'll begin exploring how drugs interact with the immune system, managing inflammation, infection, and autoimmune responses. But for now, stay here for just a moment more with the breath and the quiet work of the body at peace. As we continue our calm exploration of the body and its care, let us now turn inward to the quiet, constant vigilance of the immune system. A system designed to protect us, to recognize what belongs and what does not. It defends the body against invaders such as bacteria, viruses, and fungi. Sometimes, however, it needs support. And that's where pharmacology gently steps in, to assist, to balance, and to restore peace within. In this section, we'll explore how medications help the immune system and how they act against infection. Let's begin with a broad class of medications known as anti-infectives. These are drugs used to treat infections. They include antibiotics, antivirals, antifungals, and others that target specific pathogens. We'll start softly with antibiotics, medications used to treat bacterial infections. Bacteria are small, single-celled organisms. Some are harmless. Many even help us. But others can cause illness, such as pneumonia, urinary tract infections, or skin infections. Antibiotics work by interfering with bacterial survival. Some attack the cell wall, a protective outer structure that human cells do not have. Others block the processes bacteria use to grow or reproduce. One of the oldest and most well-known antibiotic classes is the penicillins. Penicillins work by weakening the bacterial cell wall, causing the bacteria to burst. They are used to treat many common infections, like strep throat, ear infections, and some respiratory illnesses. Next, we have the cephalosporins. These are similar to penicillins and are often used when penicillins aren't effective, or when a broader coverage is needed. They are organized into generations, each targeting different bacteria. Another key group is the macrolides, such as erythromycin and azithromycin. These don't affect the cell wall, but instead stop bacteria from making the proteins they need to survive. As we gently compare these classes, you may hear terms like broad-spectrum and narrow-spectrum. A broad-spectrum antibiotic acts against many types of bacteria, both gram-positive and gram-negative. A narrow-spectrum antibiotic targets a smaller group, often more precisely. Choosing the right spectrum is important. Too broad and it may disrupt healthy bacteria. Too narrow, and it may miss the cause. This leads us softly to the concept of antibiotic resistance. Over time, bacteria can change, adapting to survive, even in the presence of antibiotics. This is called resistance. When bacteria become resistant, the antibiotic may no longer work. To prevent this, antibiotics should be used only when needed, at the right dose, and for the full duration prescribed. Now that we've explored how antibiotics help, let's move to antivirals. Viruses are not cells. They cannot live or reproduce on their own. They must enter human cells and use them to multiply. Because viruses live inside our own cells, treating them is more delicate. Antiviral medications work by interfering with steps in the viral life cycle. Some block the virus from entering cells. Others stop the virus from copying itself. A few prevent the virus from leaving the cell to spread further. For example, acyclovir is used for herpes viruses. Oseltamivir, also called Tamiflu, can shorten flu symptoms if taken early, and in more serious infections. Antivirals, like those for HIV or hepatitis C, may be taken long-term to keep the virus under control. Antiviral therapy is often specific, meaning one drug may only work for one kind of virus. Let's now shift softly to antifungals. Fungi include organisms like yeast and mold. Some are harmless, but others can infect the skin, lungs, or bloodstream. Antifungal medications disrupt the cell membrane of the fungus or interfere with its ability to grow and reproduce. Examples include fluconazole for yeast infections or amphotericin B for more serious, systemic, fungal infections. While antifungals are often well tolerated, some can have side effects, especially when used for long durations. Careful monitoring is part of safe treatment. Now, let's gently introduce the concept of immunomodulators. These are medications that change how the immune system behaves. Others suppress immune function to prevent it from attacking the body's own tissues. This is important in autoimmune diseases and after organ transplantation, where the immune system might try to reject the new organ. These medications are called immunosuppressants. Common examples include cyclosporine, azathioprine, and corticosteroids in higher doses. They work by dampening the immune response, reducing inflammation and preventing damage, but also increasing the risk of infections. Immunomodulators must be balanced carefully, supporting the body without overstimulating it, calming it, without leaving it too vulnerable. Now, let's softly talk about vaccines. Vaccines are not treatments, they are preventive tools. They help the immune system learn about a pathogen before it encounters the real thing. Vaccines may contain inactivated viruses, weakened bacteria, or fragments of the organism. They cannot cause the disease, but they prepare the body to fight it. When the immune system sees the real virus or bacteria later, it remembers and responds quickly, often preventing illness entirely. Vaccination is one of the most important ways we protect both individuals and communities. To gently recap, antibiotics treat bacterial infections by targeting the cell wall or bacterial functions. Antivirals interfere with virus replication, helping manage infections like the flu, herpes, or HIV. Antifungals treat infections caused by yeast or molds, often by damaging the fungal cell membrane. Immunomodulators adjust immune function, either stimulating or suppressing it as needed. And vaccines prepare the immune system in advance, a calm rehearsal for real-world protection. Together, these medications work with the body's defenses, helping restore balance and prevent harm. Each has its purpose, its rhythm, its role in the orchestra of care. As we finish this section, breathe gently. Feel the body, its quiet defenses, its readiness, its healing nature. Infections may come and go, but knowledge helps us meet them with calm understanding. Let this rest in your mind like still water, undisturbed. In the next chapter, we'll begin softly exploring how drugs affect the nervous system, from calming anxiety to relieving pain. But for now, let your thoughts settle and your breath stay steady as the body remains at peace. Now, we gently turn inward again to the quieter rhythms of the body, to the delicate world of hormones and metabolism. These systems don't often shout, they hum quietly in the background, helping the body regulate growth, energy, balance, and repair. In this section, we'll explore how medications support the endocrine and metabolic systems. We'll focus softly on common conditions like diabetes, thyroid imbalances, and disorders involving the adrenal glands. These glands release hormones, chemical messengers that travel through the bloodstream. Out of balance, pharmacology can help, offering quiet, measured support. Let's begin softly. Diabetes is a condition where the body struggles with. In a healthy system, the hormone insulin helps move glucose from the blood into the cells. But in diabetes, this process is disrupted. In type 1 diabetes, the body no longer produces insulin. In type 2 diabetes, the body becomes resistant to insulin. Therapy, insulin can be given by injection and comes in different forms. Some act quickly, others last for many hours. There are rapid-acting insulins like intermediate like NPH, and long-acting like glargine. These help lower blood sugar, either around meals or steadily throughout the day and night, so they can adjust their dose, food, and activity. In type 2 diabetes, oral medications may be used before or alongside insulin. These are called oral hypoglycemics. Let's gently explore a few main types. One common class is the biguanides, with metformin being the most widely used. Metformin helps reduce the amount of glucose the liver produces and improves how cells respond to insulin. Another class includes sulfonylureas, which stimulate the pancreas to release more insulin. Examples include glipizide and glyburide. Then there are DPP-4 inhibitors, which help increase insulin release and decrease another hormone called glucagon. SGLT2 inhibitors help the kidneys release extra glucose through urine, and GLP-1 receptor agonists slow digestion and increase insulin when needed. These medications all work together, not to overwhelm the body, but to guide it gently toward more balanced glucose levels. Now that we've softly covered diabetes, let's move to the thyroid gland. This small, butterfly-shaped gland in the neck produces hormones that control the body's metabolism, how quickly or slowly it uses energy. When the thyroid is underactive, we call it hypothyroidism. This can cause fatigue, weight gain, cold intolerance, and slowed heart rate. The treatment is simple but important. A daily dose of levothyroxine, which is synthetic T4, the main thyroid hormone. This medication replaces what the thyroid is not producing, allowing the body's metabolic functions to return to balance. On the other side, an overactive thyroid or hyperthyroidism can cause restlessness, heat intolerance, weight loss, and rapid heartbeat. In these cases, medications like methimazole may be used to reduce thyroid hormone production. Sometimes beta blockers, like propranolol, are used temporarily to calm symptoms while the thyroid is brought under control. As we transition again, let's gently visit the adrenal glands. They help manage stress, blood pressure, and fluid balance. When the body doesn't make enough cortisol, a condition called adrenal insufficiency can occur. This may be due to Addison's disease, or from long-term steroid use, prednisone, or dexamethasone. These are also used in many other conditions, including inflammation, asthma, autoimmune disorders, and as part of immunosuppressive therapy. Glucocorticoids are powerful, but must be used with care. At high doses or with long-term use, they can affect weight, blood sugar, bone strength, and immunity. So dosing is often tapered slowly and balanced carefully to match the body's needs without suppressing its own natural rhythms. In diabetes, the body struggles with insulin and blood sugar. And in adrenal disorders, glucocorticoids help replace cortisol or reduce inflammation. All of these medications work not to take over, but to restore a gentle hormonal balance. Like soft adjustments to a quiet instrument, they tune the body's systems so that energy, metabolism, and healing can unfold in peace. As we end this section, feel the slow and steady nature of these processes. Hormones flow, not in bursts, but in rhythms, measured, quiet, and deeply connected to every part of you. The medications we've just explored offer support to these rhythms. They remind the body of what it needs until it can remember on its own. Now, breathe gently. Let go of any tension and allow the soft hum of endocrine balance to settle in your awareness. In the next section, we'll begin exploring nervous system pharmacology, gently looking at how medications influence mood, sleep, pain, and perception. But for now, let your mind rest and your body remain in stillness. Now we gently enter a deeply human space, the quiet realm of pain and the ways we support the body and mind in easing it. Pain is not only a physical sensation, it is also emotional, personal, and deeply rooted in how the body protects itself. And while pain can be useful, alerting us to harm or injury, when it lingers or becomes overwhelming, we seek to relieve it with care. This section softly explores the world of analgesics medications designed to reduce or relieve pain. We'll gently look at how they work, their different types, their strengths, and their risks. And along the way, we'll bring our attention to how pain is processed in the brain and how thoughtful pharmacology seeks balance, offering relief without harm. Let's begin slowly with a few key terms. The word analgesic simply means pain reliever. These medications work by altering how the body senses pain or how it responds to it. Pain is detected by specialized nerve endings called nociceptors. These receptors send signals through the spinal cord and up to the brain. It is in the brain that pain is truly felt as a sensation, an experience, and sometimes a memory. Pain-relieving medications may act at different levels. Some reduce inflammation, some block pain signals in the nervous system, and some change the way the brain responds to pain messages. Let's softly explore the major categories of pain relief drugs. We'll begin with NSAIDs, non-steroidal anti-inflammatory drugs. These include common medications such as ibuprofen, naproxen, and aspirin. NSAIDs work by blocking enzymes called COX-1 and COX-2. These enzymes help produce substances called prostaglandins, which trigger inflammation, pain, and fever. By reducing prostaglandins, NSAIDs lower inflammation and ease both acute and chronic pain, especially pain related to swelling, injury, or conditions like arthritis. However, NSAIDs also come with risks. They can irritate the stomach lining, affect kidney function, and, in some cases, impact the heart or blood clotting. So they're used thoughtfully, especially in long-term treatment. Next, we gently turn to a familiar medication, acetaminophen, also known as paracetamol in some regions. Acetaminophen is not classified as an NSAID because it does not reduce inflammation significantly. Instead, it works mainly in the brain, possibly by affecting prostaglandins in the central nervous system. This makes it effective for mild to moderate pain and for lowering fever. It is often the first choice for headaches, muscle aches, and general discomfort. Acetaminophen is generally gentle on the stomach, but it has one important caution. In large doses, it can damage the liver. So, even though it's widely available, its use must still be measured carefully. Now, let's approach the more powerful class of analgesics, opioids. These medications are reserved for moderate to severe pain. They work by binding to specific receptors in the brain and spinal cord, called mucoid receptors. When these receptors are activated, the perception of pain is reduced, and feelings of calm or even euphoria may arise. Examples of opioids include morphine, codeine, oxycodone, and fentanyl. They can be very effective, especially after surgery, during cancer treatment, or in palliative care. But with their strength comes complexity. The body can develop tolerance to opioids, meaning higher doses are needed over time for the same effect. In some individuals, dependency can develop, where the body becomes reliant on the medication to function normally. There is also a risk of addiction, which involves changes in behavior and emotional patterns, not just the physical need. Because of this, opioids are used with close monitoring, clear guidance, and deep awareness of both their benefit and their risk. Now that we've softly met the main types of analgesics, let's explore how healthcare providers approach pain relief safely. The World Health Organization developed a guide known as the Analgesic Ladder. It offers a stepwise method for managing pain, especially in cancer care. The idea is to start with the mildest effective medication and move upward only as needed. At the first step are non-opioid medications like acetaminophen and NSAIDs. If pain persists, mild opioids, such as codeine, may be added, and for severe pain, strong opioids, like morphine, may be used, sometimes in combination with other drugs for better control. This ladder isn't rigid, but it encourages thoughtful escalation and careful assessment of pain at each stage. Let's take a soft moment to gently summarize. Pain is a natural signal, but when it becomes persistent or intense, it can be eased through pharmacology. NSAIDs reduce inflammation and pain by blocking prostaglandins. They help with pain related to injury or swelling. Acetaminophen acts mainly in the brain, reducing pain and fever with fewer stomach effects, but it must be used within safe limits to protect the liver. Opioids are strong pain relievers that work on the central nervous system. They bring comfort during serious pain, but must be used mindfully to avoid tolerance, dependence, and addiction. The WHO Analgesic ladder reminds us to start gently and to increase treatment only when needed, always respecting the body's balance. Pain management is not just about stopping discomfort, but about restoring peace, allowing rest, allowing healing. And so, we approach this topic not with fear, but with understanding. Each medication, each choice, carries both a purpose and a responsibility to support, to protect, and to honor the person in pain. As this section settles, let your breath ease and your thoughts drift softly. We've now gently completed our journey through analgesics, from the everyday relief of acetaminophen to the careful use of opioids. We've seen how pharmacology listens to the body's signals and offers relief with awareness and compassion. In the next section, we'll begin to explore the medications that shape the mind, including antidepressants, anxiolytics, and antipsychotics. But for now, simply rest and allow the understanding to settle like a gentle wave withdrawing, leaving stillness behind. Now, we arrive at a more solemn chapter, one that invites us to listen deeply and softly to a topic that touches many lives, yet can still be approached with clarity and calm. This is the space of oncology, the study of cancer, and the pharmacological tools used in its treatment. Though complex, will move through it slowly, with gentle attention and quiet understanding at its heart. Cancer is a condition of unregulated growth. Normal cells grow, divide, and rest in balance. But in cancer, certain cells begin to divide too quickly, without stopping, without maturing properly, and without responding to the usual signals that guide healthy tissue. Chemotherapy or anti-cancer drug therapy aims to stop or slow this abnormal cell division. It works by targeting cells that multiply rapidly, which is a key feature of many cancer cells. But this approach also explains why side effects occur. Because some normal cells in the body, like those in the hair, the lining of the gut, and the bone marrow, also divide rapidly, and so they too can be affected. Still, the purpose of chemotherapy is to support the body, to reduce the tumor burden, to slow disease progression, and in many cases, to offer the possibility of remission or cure. Let's now gently explore the major types of chemotherapy drugs, one by one, with soft definitions and steady pacing. We begin with a class known as alkylating agents. These medications work by adding alkyl groups to DNA, disrupting its structure and preventing the cancer cell from replicating. This interruption causes damage that the cancer cell cannot easily repair, and as a result, the cell stops dividing and may undergo apoptosis, a form of programmed cell death. Examples include cyclophosphamide, efosfamide, and cisplatin. They are often used for a variety of cancers, including lymphomas, leukemias, and solid tumors. Next, we softly turn to anti-metabolics. These agents mimic the natural building blocks of DNA and RNA, but instead of helping, they interfere, disrupting the normal synthesis of genetic material and halting cell division. Common antimetabolites include methotrexate, 5-fluorouracil, and cytarabine. They are used in cancers of the breast, colon, and blood because they act during the DNA synthesis phase of the cell cycle. Antimetabolites are especially effective against cells that divide quickly, making them powerful tools in early-stage or fast-growing cancers. Now, let's softly introduce monoclonal antibodies. These are more recent and more targeted therapies. They are lab-created molecules designed to recognize and bind to specific proteins, often found on the surface of cancer cells. Once bound, they can mark the cell for destruction by the immune system, block critical growth signals, or deliver toxic agents directly to the cancerous tissue. An example is trastuzumab, which targets the HER2 receptor in some breast cancers. Another is rituximab, used in certain types of lymphomas and leukemias. These therapies offer precision and are often less toxic to healthy tissues compared to traditional chemotherapy. We now gently move into a related area, targeted therapies. These medications do not affect all rapidly dividing cells. Instead, they act on specific molecular pathways that the cancer cells depend on. They may block enzymes, inhibit growth receptors, or alter signaling processes inside the cell. Targeted therapies include tyrosine kinase inhibitors, such as imatinib, used in chronic myeloid leukemia. They represent a shift in how we think about treatment, focusing not just on killing cells, but on disrupting the biological signals that support cancer's growth. These newer drugs tend to have different side effect profiles, and while not without risks, they offer more personalized approaches, sometimes based on the genetic features of a patient's tumor. Now that we've quietly reviewed these classes, alkylating agents, antimetabolites, monoclonal antibodies, and targeted therapies, let's reflect gently on the broader picture. Chemotherapy is not a single medicine, but a family of strategies. It may be given alone, or with surgery, or alongside radiation, depending on the type of cancer, its stage, and the person's overall health. And while side effects are real, from nausea to fatigue, from hair loss to immune suppression, supportive care has grown alongside chemotherapy. Medications to reduce nausea, growth factors to boost the bone marrow, and mindfulness around dosing and timing have all made treatment more tolerable. Most importantly, cancer pharmacology is never just about the medicine. It's about partnership between the science and the body's resilience, between treatment and healing, between the effort to fight disease and the gentle care of the whole person. Let's softly recap before we close. Cancer is a disease of uncontrolled cell growth. Chemotherapy works by stopping that growth, particularly in rapidly dividing cells. Alkylating agents damage DNA directly. Antimetabolites disrupt the building blocks of genetic material. Monoclonal antibodies use the immune system or targeted binding. Targeted therapies interrupt molecular pathways that cancer cells rely on. All of these therapies aim to restore balance, to protect the healthy parts of the body while slowing or stopping the disease process. As this section comes to rest, take a quiet moment to appreciate the calm intention behind each treatment. Even in difficult conditions, pharmacology remains a steady guide, offering options, offering hope, offering care. In the next section, we'll move from the body to the microbes that live around and within us, and explore the gentle power of antibiotics and antimicrobial agents. But for now, rest in the soft knowing that every system, even when challenged, can be supported with knowledge and care. Let it settle, let it ease and breathe softly. Let's now drift into a quieter space, a space of awareness and gentle attention. So far, we've explored how drugs work, how they act on the body, and how they help restore balance and response. In this section, we'll softly explore what happens when a drug's effect moves beyond what was intended, when the body reacts in ways we didn't fully expect, and how we can understand those reactions with calm curiosity. We begin with a simple yet important idea: adverse drug reactions, often called ADRs. These are unwanted or harmful effects that occur when a medication is given at the correct dose. They may be mild, like a dry mouth or slight drowsiness, or more serious, such as organ toxicity or allergic responses. Adverse reactions are not always signs that something is wrong, but they do tell us something. They remind us that every body is unique, and every substance, no matter how helpful, must be used with care. Now, let's slowly distinguish side effects from more severe adverse reactions. A side effect is a known, often expected, secondary effect of a drug. For example, some antihistamines can cause drowsiness. Some antibiotics may lead to mild digestive upset. These effects are not necessarily dangerous, but they can still affect quality of life. On the other hand, an adverse drug reaction is typically less predictable and may require stopping or adjusting the medication. Things like skin rashes, difficulty breathing, changes in heart rhythm, or liver enzyme elevations. They can arise from the drug's direct action, from how the body metabolizes it, or from interactions with other substances. Let's gently pause here to introduce the idea of drug allergies. Allergies are a specific kind of adverse reaction caused by the immune system reacting inappropriately to a medication. Instead of seeing the drug as harmless, the body treats it as a threat. This can result in symptoms like rash, itching, hives, and in more serious cases, anaphylaxis, a rapid, life-threatening reaction involving airway swelling, low blood pressure, and difficulty breathing. Drug allergies are relatively uncommon, but important to recognize. They are not dose-dependent. Even a small amount of the drug can trigger a response once the immune system has become sensitized. Now, let's shift gently to another concept: drug interactions. Drug interactions occur when the effects of one drug are altered by the presence of another substance. This could be another drug, a food, a supplement, or even alcohol. These interactions may increase the drug's effect, reduce it, or create entirely new effects. For example, some medications that are broken down by the liver can build up to higher levels. If another drug slows down the liver's metabolism, this can increase the risk of toxicity. Other times, one drug might reduce the effectiveness of another. As with certain antibiotics that interfere with birth control pills, food can also play a role, with liver enzymes affecting how some drugs are absorbed. Softly remembering this concept can help guide safe use. What we take and what we take it with can deeply influence how the body responds. As we continue, let's talk about polypharmacy. This term refers to the use of multiple medications at the same time, often seen in older adults or those managing several health conditions. Polypharmacy isn't inherently negative. Sometimes it's necessary and carefully managed, but it can increase the risk of drug interactions, duplicate therapies, and unexpected side effects. The more medications involved, the more complex the picture becomes. It becomes a delicate balance, a puzzle that needs ongoing attention and care. Closely linked to this is the concept of contraindications. A contraindication is a situation where a drug should not be used because it may cause harm in a specific person or condition. For example, some drugs may be contraindicated in pregnancy because they can affect fetal development. Others might be unsafe for people with liver disease or certain heart conditions. Contraindications may be absolute, meaning the drug should never be used, or relative, meaning it may be used if the benefits outweigh the risks, but with caution. This brings us to an essential reminder. Pharmacology is not just about prescribing drugs, but about knowing when not to prescribe them. It's about understanding the body's signals and adjusting the approach with mindfulness. Let's softly recap what we've gently absorbed together. Effects asterisk are expected secondary effects of medications. Adverse drug reactions go beyond these and may be harmful, unpredictable, or severe. Drug allergies involve an immune response, sometimes life-threatening. Drug interactions happen when one substance changes the way another drug works, making it stronger, weaker, or unpredictable. Polypharmacy can increase risks, especially when several drugs interact. Contraindications tell us when a drug should be avoided or used with great care. All of these concepts point toward one gentle truth. Medication is powerful, but power must be balanced with respect, with attentiveness, and with a willingness to pause and listen. Pharmacology, at its core, is not only about action, it is about vigilance. It is about being alert to changes, to unexpected responses, and to the quiet wisdom of the body itself. As we close this chapter, let this awareness rest softly within you. Let it remind you that every medicine tells a story, not only through what it treats, but through how it is received and how it affects the whole being. In our next section, we'll continue this quiet journey, exploring the world of antimicrobials and how they gently defend us against the smallest, yet most persistent of life forms. But for now, breathe deeply and let this knowledge settle like a calm ripple on still water. As we reach the final chapter in our quiet journey through pharmacology, let us settle gently into stillness and allow the ideas to soften as if melting into the background of the mind. This is not a time for summary or review. There is no need to remember or recite. Instead, we simply rest in quiet reflection. Pharmacology is often taught as a science, and indeed, it is a science, a deeply structured exploration of how molecules move through the body, how they bind, how they transform, and how they affect change. But if we look just a little closer, we begin to see something more. Pharmacology is also an art of timing, of dosage, of knowing when to act and when to wait. It asks not only what does this drug do, but also what does this person need? In every drug we've discussed, From the gentlest analgesic to the most targeted chemotherapeutic agent, there is a story of balance, of helping the body heal without overwhelming it, of guiding a process rather than controlling it. Let your mind drift softly now over the pathways we've walked together. We've touched on how drugs are absorbed, how they move through the bloodstream, and how they find their way to the tissues they are meant to reach. We've seen how enzymes in the liver can change a drug's structure, sometimes activating it, sometimes preparing it for release. We've looked at how drugs interact with receptors, how they block or mimic or enhance natural signals, and we've explored how they leave the body through urine, through bile, through breath and sweat and time. All of this flows in harmony with the body's natural rhythms. Pharmacology is not a battle against disease, but a dialogue with physiology. It is a quiet listening, a gentle nudge in the direction of healing, even when the drugs are strong. As in chemotherapy or emergency medicine, there is still an underlying respect for the complexity of human life. And so we begin to understand that every drug is a decision, a weighing of risks and benefits, a consideration of individual needs, a moment of trust between clinician and patient. To practice pharmacology well is not only to know the facts, but to see the person before you, to hear what their body is saying, and to choose, with care, what might help them most. Let this thought rest with you, that medication is more than a substance. It is a relationship between science and compassion, between knowledge and care. As you drift deeper into rest, you may notice that many of the details have faded gently into the background, and that is perfectly okay. They are still with you, somewhere quiet, somewhere calm. This video was never about memorizing, but about familiarizing, about creating a soft place in the mind where ideas can return without pressure, without strain. What we've shared here will gently settle into your awareness, and when needed, you may find it again, not as something forced, but as something remembered from a place of stillness. Let this final chapter be a reminder that knowledge can arrive like a whisper, not just through effort, but through presence. That learning, especially in the healing arts, is not only what we know, but how we apply it, how we approach others, and how we remain humble in the face of the body's wisdom. Pharmacology teaches us structure, but it also teaches us sensitivity. It invites us to understand, to notice, and to care. And now, as the lantern dims and the path grows quiet, you may feel a soft sense of closure, not from reaching an end, but from coming to a place of calm understanding. There will always be more to learn, more to explore, but for tonight, we rest in what we've gathered. We let it settle, we let it be. And whether you are fast asleep or simply drifting in thought, know that this space of learning remains open, quiet, patient, welcoming. Let the breath slow, let the mind release, and allow this gentle journey through the art and science of pharmacology to fade like the softest sigh into peaceful rest.